Hello, good afternoon. I'm Alfonso Jurado from La Paz again, from Madrid. It's a pleasure for us to be here again with the second live case of the day. That is a coronary case. Here in the CAD lab, I have beside me Dr. Galeote and Carmen. Pilar is also here, and Monica as the nurses. And outside, we have Sandra Rosillo, that is one of our colleagues from the acute cardiac care unit. And also Clara Hueto, that is the resident who is going to present the case. So Clara, please.
Hello, good morning. I'm going to present the 79-year-old male. He has a story of hypertension, diabetes, and dyslipidemia, and he had a previous ictus. He also has a severe kidney disease with in April, he was hospitalized with a diagnosis of acute heart failure with severe dysfunction of the left ventricle. In the electrocardiogram, he has a left bundle branch block, and in the blood test, he has a 2.9 milligrams per deciliter of creatinine, which corresponds with a glomerular filtration of 26. During the hospital stay, a coronary angiogram was done showing severe ischemic coronary disease. The patient started treatment with 2 antiplatelets with clopidogrel and aspirin, and now we are going to do the revascularization. Here you can see the coronary angiogram. He has a severe disease of the proximal anterior descendant artery, and he also has a severe disease of the circumflex in the distal zone. We also see that the right artery has disease in the descendant posterior artery. The syntax score was low, about 18 points, but the Euro score and the STS mortality risk score is very high, about the 18% of risk, and that's why we are going to do the revascularization by percutaneous revascularization. So we are going to do also a low contrast PCI guided by IVUS because the severe kidney dysfunction that the patient has, and we are going to support the angiography angioplasty, by an intra-aortic balloon pump because of the severe dysfunction. There is not a consensus about the best approach to do or to support the angioplasty, only the opinion of experts. And we have here Sandra Rosillo, who is a cardiologist that works in the coronary unit, that is going to explain to us a bit more about this.
Hi, good afternoon or good morning for wherever you're connected. My name is Sandra Rosillo and I work in the acute cardiac care unit. And we were consulted about this case as it is considered to be a high-risk procedure. So our colleagues from the cath lab wanted to know if this patient was an appropriate candidate to receive a mechanical support. So based on the actual evidence, we know that nowadays to establish which patient is a high-risk revascularization patient is very hard. No, we have 3 main criteria. The first criteria belongs to the characteristics and the history of the patient. No, usually these patients have an old age. They have a lot of diseases, kidney disease, chronic kidney disease, previous history of heart failure, decompensation. Then we have the criteria of the anatomy that's going to undergo the revascularization. And usually what's considered as high risk is a left main or 2 vessels that are equivalent to a left main or a 3-vessel disease. No, usually the 3-vessel disease must be at least proximal. And then the third criteria, usually the hemodynamic criteria, which is usually based on the left ventricular ejection fraction. So nowadays, in 2022, we still lack of a lot of evidence. There are only 2 randomized controlled trials that talk about this topic. One of them was performed on 2010, that is the VCIS trial, which you know that was they compared with reduced left ventricular ejection fraction less than 30%, and they randomized the patients that underwent a high risk revascularization to receive an intra-aortic balloon pump or to go normal non-supported revascularization. And in this study, in the acute event during hospitalization, they didn't find any difference between the patients that had an intra-aortic balloon pump and those that underwent a regular revascularization. But they made a follow-up of about 5 years of the patients, and at 5 years, they saw that the results were better. The patient had less coronary events at 5 years of revascularization. And even though this study was not designed to prove this objective, mainly in the United States, they adopted the tradition of performing high-risk PCI with the intra-aortic balloon pump. It's true that in Europe, we were a little bit less believers on the results, so we didn't take this course of action of making every procedure under a balloon pump support. And then the second randomized control trial, the other big one, or bigger, a little bit bigger than the other one, is also already from 2012, so it's not very actual. And it's a protective trial, which compared patients of high risk revascularization that were considered those with a left ventricular ejection fraction under 35% and a left main disease, or under 30% with three vessel disease. And in this trial, they randomized the patient to receive either an intra-aortic balloon pump or an Impella 2.5, because it was 2012. And in the per protocol analysis and intention to treat analysis, they didn't find any difference regarding the MACE. The problem here is that the primary endpoint was a complex primary endpoint with a lot of variables, including high rise of troponin, of CKMB, stroke, aortic regurgitation, cardiac heart failure. So it was a very complex endpoint. Then the Protect 3, it was not a randomized controlled trial. And in between, we have a lot of... Sorry. And on the Protect 3 trial, it's not a randomized trial, but in between we have a lot of observational trials that have very, very, very different results. Now, some of them, for example, the Italian cohort have a mix of cardiogenic shock patients and high-risk revascularization patients. And in that cohort, they have very bad results, mainly because they had a lot of vascular and hemorrhagic complications in the vascular end. And then the more updated registries, they have better results because we have updated mainly the way to insert the mechanical support. No, usually it is echo guided, no, and with microneedles. So now we are seeing a reduction in the more recent registries of the vascular complications of the patients. And there is a doubt that maybe it can also have a benefit on regards of the renal function of the patients. So our decision, after talking about the case with the colleague, we decided that yes, this is a high-risk patient. No, we said before that he's over 75. He has a chronic kidney disease. He has had a previous stroke. He has a reduced left ventricular ejection fraction, and the anatomy, it's the one that we saw first. No, the more proximal vessel is the left anterior descendant artery, and then the lesions that we see in the circumflex artery and in the right coronary artery are a little bit less proximal. So that's why we finally made the choice of supporting this procedure with an intra-aortic balloon pump.
Issues about doing this kind of procedures with left ventricular support. So regarding the protection of acute kidney injury, the patient has a very low glomerular filtration rate. and we are put a threshold of contrast just to not use more for this procedure. So give me a test. So we are trying to perform the multivessel vascularization, but starting from the left tree, and only if we are able to complete it with less than 40, 50%, 50 cc of contrast, we will continue with the right coronary artery. So I think everything is explained. I don't know if any question from the audience, Clara, or?
1 second, I see. No, we don't have any questions yet.
Okay. Regarding the technical aspects of the coronary arteries, the more tricky lesion, in my opinion, is the left anterior descending. You have seen the angios before. We are doing some more angios now because it has some tortuosity. It's a calcified lesion. It's also a bifurcation, but the side branch is occluded, so we are going to forget it and trying to minimize the contrast volume. And we are trying not to use the atherectomy devices because of the left ventricle dysfunction, and try to see if with semi-compliant or non-compliant balloons, the dilation, the expansion is okay. So now the setup, we have the intra-aortic balloon pump to the left femoral artery, echo-guided puncture is working now. And we have a radial approach, a slender sheath 7 French with an EVU 7 French in the left main. We have crossed 2 wires, a cyan blue wire that is our Warhawks one in the circ that cross indeed to the lesion we are going to treat. And struggling a little bit more during the speech of Sandra, I crossed cyan black to the distal LAD, as you can see here. In these cases in which we aim to perform a low contrast PCI or ultra low contrast, there are also colleagues that are doing 0 contrast PCI, but I think it's just an exaggeration and it's magic, no? We are trying to start with the LED, Guillermo, or the circ?
No, I think the LED is
our initial plan was the LED, but we crossed before to the circ and was tempted to start with the circ. So let's try to predilate a little bit because the IVUS is not going to cross. So please, 1.5 or Guillermo?
Okay.
Un balón de 1,5, porfa.
I think that is important that the contrast is bicipaque. That is a isosmolar contrast. No, I think it's better for the kidney than the other.
You rate 1,5, 10.
We always use a bicipaque contrast from General Electric, and I think it's very, very good for interventional cardiologists.
No, for this patient to perform a low contrast and protect the acute kidney injury, that in this patient with chronic renal failure, the rate of acute kidney injury goes up to 30%, and it impacts in mortality and other MACE. There are several tools you can use. Of course, IVUS for me is the main one to guide the procedure with IVUS and avoid unnecessary injections of contrast. Also, that Guillermo said, use low osmolar contrast media.
This is isosmolar.
Yeah, iso or hypoosmolar, it depends, but it's true. And another tricks are, of course, to delay the PCI, not doing at the same procedure of the diagnostic angiogram. Use this previous angiogram as a roadmap to avoid more injections the day of the PCI, and also to use this metallic roadmap with the wires in the side branches or whenever you want to avoid contrast. So we are going to see if the 1.5 balloon cross the tight lesion, the tight and the calcified lesion of the LAD. Let's see. Okay. Okay, I think it has crossed.
Yeah.
Let me check the previous angio.
I think a little more. No,
A little bit more, yeah. A little bit more. The lesion is long. It's almost 38, 40 millimeters. I think the distal landing zone is almost there.
Yes, yes. I think it's okay.
Dilate, please. Of course, we had prepared the Rota Pro system just in case the balloon didn't cross.
¿Cuál es la presión de ruptura? ¿No?
And after this inflation, we are doing IVUS. If we thought the IVUS could cross initially, we have done it, but in this case,
14?
I'm pretty sure that the IVUS cannot cross with this critical lesion. Okay. If you are seeing the hemodynamics, the intra-aortic balloon pump is doing its
14?
job. 18.
18.
Okay. Another more proximal, the last one. Okay, there. Okay, perfect.
Okay, 16.
Okay, let's go with the IVUS.
Okay. IVUS, please. This IVUS from Boston.
Okay. Okay.
Okay. Thank you. Un momento.
Enciende la luz, ellos no ven nada.
Un segundo eso. Porque no veo nada, soy yo.
Another difficult part of the procedure just to insert the IVUS in the wire.
Es que dame la luz aquí. Es que si no veo es que no veo nada. Ahora sí. Thank you very much.
Okay.
Be patient, please. Be patient with the old man.
Have the wire? Okay. Okay, let's see. We have Laura, I don't know if it's Santiago Jiménez Valero as well outside, just to measure the IVUS. Let's see if the catheter cross. Some colleagues are using also OCT with dextran or saline to avoid contrast, but I think the image is quite worse than with contrast. IVUS is struggling a little bit to cross the lesion, as you can see there, but I think. Okay.
IVUS live, please. IVUS live. Es que no sé por qué se está dando solo, ¿no? Está activándose solo.
It's another trick when the IVUS don't cross. We haven't done it on purpose, but when the IVUS don't cross, if you activate the motor, sometimes process. Now it has done that. So let's put live. Okay. I think it could be the distal landing more or less. They're going to flash a little bit. Could be. So pull back from here. Some disease there. Probably vessel is, we are doing some measurements, but probably 2.5 to 3 distal vessel. This is a branch coming at the bottom of the image. And this comes the tight lesion embracing the IVUS catheter, severely calcified. And we are reaching the proximal part. This is a big vessel here. And probably the landing is near here because we have the other wire in the circ. And we will see, this is a good point.
Yeah.
And the other branch and the circumflex wire is there. So this is the left main. Okay. Stop. We will have some measurements, Laura. Just the distal reference diameter. The proximal one, the length, and we will check the classification just to decide if we need for sure a bigger non-compliant balloon, but probably something else. I don't know. This is a distal reference, probably 2.75.
Yeah, I think so.
3.5 probably. Yeah, this is from EM to EM. Probably I would go, I don't know. I will be more conservative probably, and then post-dilate if we can. So let's try with an non-compliant balloon.
Non-compliant, no?
2.5.
Or 2.75.
2.75 non-compliant balloon, please.
2.75.
Yeah. Can we see the more calcified plaque, Laura?
15, por ejemplo.
Yes, at some point we have 180 degrees. It's difficult to understand the depth of the classification. We have some reverberation there. There are some controversial point about these reverberations that some articles said that it implies a thin calcifications. In other more recent said that we are not sure about that. Hopefully the calcium plaque is thin, and we are going to dilate it or trying to dilate it with a non-compliant balloon. And the length, Laura, yeah, probably 40 something or what? 45. Yeah. You have the wire?
Le pusisteis toda la heparina, ¿no?
Sí.
Y está precargado, ¿no?
Sí. The patient has been treated all this past week by our colleagues from the clinical cardiology department, improving the renal function to the best the patient can. Probably is there.
Yeah.
Let's check the initial angio.
Is second curve, no?
The second curve.
Yes.
I have some difficulties here. I think we can dilate here because there's some accumulated friction.
$18.
I think the expansion is okay. This is not the more calcified plaque. In the next inflation, we are going to confirm in two orthogonal projection that the expansion is good. Okay. There are some bubbles, but I think the expansion is good. Maintain the inflation, please.
18.
Okay, just to check. I think the expansion is okay. Down. Hemodynamics are okay. 18. I think it's a bubble, but maintain it. I think expansion is good. Probably it was a thin calcium plaque at this point. And the last one, no, Guillermo?
Vale. Okay.
Probably there. Yeah, this is a curve, but the
20.
expansion is quite good in my opinion.
Mhm.
Okay, let's check in the projection, maintain it. I think so. It's just a curve. Okay.
Can we use a bigger balloon for the proximal LED or?
Yes, we can do it. 3.5.
Okay.
Balón 3,5 NC. Usually we perform some injections after the inflations just to confirm there is no perf. But in this case, we are looking for the ECG, the pressures, everything is okay. 15. Everything is okay, so we are avoiding this step. Okay. Is there any questions, Clara? Are there any? A question? I don't know if I understand well the question about the transradial, the relationship between the renal failure and transradial access. We try to perform all the procedures by transradial access. We perform a lot of cheap cases, CTOs, and we have moved to the biradial approach. Even in these cases, we use the slender sieve 7-in-6. So you know that is a careful with the wire.
Sí.
You have an inner lumen of 7 French, but an outer one of 7, just thinning the wall of the sheath. And you can do almost everything with 7 French. So we go probably from here.
Yeah.
With 7 French for almost every complex case like this. Of course, the intra-aortic balloon pump needs to
14
to be inserted through the femoral approach. I think it's okay. Another more proximal, probably.
Yes, I think so.
Okay, dale.
Yeah. 16.
Bueno.
Parece que está bien, sí que es.
So let's choose the stent. Everything is okay. The ECG, the blood pressure. So the length, if I am right, is 45 something. It's to
Cuidado con ella ahí,
la CX, no pasa otra vez.
Es la
CX.
Me
Okay.
pido un poco, no sé.
I don't know if it's too confident by myself to try to advance 48 directly, or we can try it.
Or
At
an
2.5.
no? A new IVUS, no? I think is.
Yes, we can do it.
No?
Just to check if the lesion is prepared.
Nitro, please.
Let's do IVUS again.
Nitro and IVUS. I think. IVUS.
I don't know if Sandra is there. Con Salina, ¿vale? La empujamos. Un segundo. Vale. Vale.
Vamos a mirar muy bien la guía porque se avanza la puñetera guía.
Relatively infrequent because as I told you before, we are still waiting like for solid evidence. It's true that here in the cath lab, they have a lot of experience with the vascular accesses, and
Yes.
usually perform them with echo guided and with micropuncture. So we usually do not have many complications, but our main use for Impella or ECMO is for the acute this decompensated patient, no? Either because of cardiogenic shock or for acute heart failure, or a more acute scenario. Usually in the program scenario, as we believe that you also have a high risk of complication, and we still don't have a lot of strong, solid evidence from randomized control trials, we tend to be a little bit more conservative on that scenario.
Muy bien.
Perfect. I think we are there.
Well, new IVUS.
Que está moviendo la mesa. This is the distal portion, probably is there, probably some dissection there. The vessel has improved a lot.
Yes, usually I have a question here. Does the heart team review all chip cases? Yes, we always perform, we have actually every day from Monday to Friday a heart team session where we always discuss the complex high-risk patients. And we usually work together, the cath lab team and the acute coronary unit, to have better results. So we usually, if the case is very complex, one of the members of the acute cardiac team is usually present in the room, and we always have a bed ready in case we have any complications. So yes, we go through a heart team session, yes. Also with cardiac surgeons and with the imaging team, so.
Okay, we can analyze this IVUS after the predilation in the run. I think I've seen some fractures at the more calcified part. With nitroglycerin after the dilations, I think the diameter of the vessel has improved a lot. And after this run, we can decide if we need more plaque modification or going for the stent.
60 podría ser, ¿eh? El run ha sido 63.
El tema es que pasamos 60.
Sí, lo que pasa, ¿eh? Y luego postilateral. Distales 3, 299. $45. Bueno, no parece tanto ahí, entonces. Ahí es. El ramo.
And the proximal part, okay.
Un 348, entonces. Ahí.
Yes, I think we can go. The distal reference vessel probably is 3 now.
Sí que
yeah, it's 3 more or less. So we can, my only doubt is if we can cover all the lesion with a 48 stent, probably not. With this measurement, 52 millimeters. So the question if using 2 overlap stents, so only one of 60, this morph tapered stents. Probably because of this tortuosity and calcification, I think we can use a 3 point something for the mid part of the vessel and a 3.5 just to have more options to overdilate the proximal part. What do you think?
Maybe no, I think it's a good option, but I have the feeling the 60 stent, I think, can be work, but
we can try. We have the morph stent. There are 2 questions.
Yeah,
just a second, Clara. Just a second.
Okay.
We have the morph stent that is a tapered stent of up to 60 millimeters of length. That is tapered, so the balloon is tapered. So at the proximal part, you achieve, for example, 3.5, and the distal part 3 millimeters without the need of overlapping. So, podéis mirar si tenemos un morph de 60, de 3,5, 3.
We have 3 more questions. The first one is, which anticoagulant are you using?
Yes, it's easy. We always use, or almost always, fractional heparin. Some of our colleagues, indeed, Guillermo is using bivalirudin for STEMI procedures, but in general, in elective ones, we use a fractional heparin.
Okay, thank you. The second one is, has lithotripsy decreased your incidence of rotablator?
Probably. This is a very good question. As you know, lithotripsy is a safe and effective tool to modify calcium, and probably the learning curve is easier than rota. Here we have a lot of experience with rota, but to be honest, we are doing some randomized trials, and patients with severe calcified lesions in general are randomized for this trial. So they undergo lithotripsy, rota, also laser or orbital atherectomy regarding the trial. Probably answering the question, lithotripsy has reduced a little bit the use of rota, but I think they are complementary tools.
Okay, thank you. And the third one is, how are you deciding between IVUS and OCT?
Ya está. Pues ya baja, ¿no? Sorry, Clara.
Sí, the question is, how do you decide between IVUS and OCT?
Sorry, Clara, we are talking about here.
It's okay, yeah.
Just a second, we are advancing the stent, and then we will answer the question.
Perfect, yeah.
So this is a morph stent, 60 millimeters in length, 3.5 in the proximal part, and 3.0 in the distal one. As Guillermo advanced, the stent is advancing with some struggles, but quite well. And I think we are almost there.
Dejarme las presiones, joder.
I think we are almost there. Let's check the initial angio.
Esa es la que falta contestar. No ha contestado las tres. Bueno, la última no hace falta. Pero how do you handle CKD?
I am seeing only the proximal part, just to know where. Okay, can I have a slide test, please? Okay. I did it more, please.
Yes, it's water inside the catheter. More?
Sí. Okay. Okay. I think we are there.
Okay.
Let's go. We have the wire in the circle as a marker, and we are covering all the proximal part of the LAD, just to the nominal pressure.
Just it's 10.
Just
only 10.
I'm concerned of the distal part of the
10.
go down, because the patient does not tolerate so well. Okay. Go down. Please give me a syringe, una jeringa, por favor.
A ver. Esto va rápido, ¿eh? Está bien.
Rápido, leche. Okay. Okay. Everything is fine. Let's retrieve the stent, and then we can answer more questions. Just 5 seconds.
Le pregunto que si quiere que conteste.
Yes, Sandra, if you can answer any question, please.
Okay, yes.
Go ahead.
So one of the questions is, how do you handle AFib and chronic kidney disease? So AFib, in this case, the patient doesn't have a history of AFib, but as it is a complex revascularization, if that was the case, I think that the question might be directed towards the management of the dual antiplatelet therapy and anticoagulation. Well, he or she at least would be here during the in-hospital stay under triple therapy. And then when they go home, we usually reduce the therapy to clopidogrel and direct anticoagulant, rivaroxaban or dabigatran or any of the direct oral anticoagulants. And then on regards to CKD, the intention of this patient is to perform a low contrast catheterism, as Alfonso explained before. And then we believe that there are small data on the improvement of hemodynamic stability, that then you will have a little bit less kidney complications. and if necessary, if he needs if he was more close to dialysis, sometimes we even perform prophylactic hemodiafiltration or any other renal substitution therapy, but he's not in that case. He was not a pre-dialysis patient, so we will just make a close follow-up, and we believe that if he's hemodynamically stable and if we use a low contrast strategy, then hopefully he will not have a lot of perfusion like in previous cases.
Mírala ahí. Mira ahí, espera que se viene. Tírala un poco de ella, sí, no, porque tenemos mucha y...
Alexandra, is another question or?
Yes, there's another question. Which IVUS manufacturer do you use?
It's a very good question. We are using now the Boston IVUS. We also have the Volcano Philips one, and both have pros and cons. The definition, of course, is better with the optic with the Boston one, but the Volcano Philips IVUS has also some advantages, as the Coriolis C, and the Eagle Eye has the lens at the tip, and probably it's a good option for some cases as CTO or other ones. We are now post-dilating a little bit the proximal part of the stent with the 3.5 balloon we used before. From here.
Yeah.
Okay, and
16?
another question, or I wait a little bit.
Yes, we can answer it.
Okay, the other question is, watching you from the US, are these products you use available in the US? We would love to know more about them as you're using them.
I don't know, probably Laura can answer better than me. Of course, IVUS is available. Yeah, it's available. I don't know if the Morph stent is available there.
Morph stent? No sabemos.
Okay, we don't know about the Morph stent. We have some experience here with it, and there are some data comparing these very long platforms against overlapping two stents. And there are pros and cons, but
20.
One of the advantages of using only one is that you reduce the need of contrast injection just to check the overlapping site and the expansion of both stents. So this is a very good option that Guillermo suggested. Okay.
And then one of the other questions is, how are you deciding about IVUS versus OCT?
Okay, this is a very common question. Just a second. Un NC3 15, porfa. You know that OCT has a better resolution, but the problem is with OCT regarding especially to this patient is that you need to remove blood from the coronary artery just to be able to see the vessel. So this is done usually with contrast. And if you are trying to perform an ultra low contrast PCI, IVUS, in my opinion, is the best option. So as I said before, I think some colleagues are doing OCT with other options different than contrast, as Dextran or Saline, but the image is quite worse than with contrast. In this case, I think IVUS give us everything we need to know: the morphology of the plaque, the distal and proximal reference, the length of the lesion, the modification of the plaque after balloon inflation, and the final result. Yes. We are going to post-dilate the distal part of the stent, not the distal end, no, just in the middle, with a 3.0
in distal, but inside the stent.
Inside the stent, okay.
I think about your question about the Morph stent, probably in USA is not available because it's a stent from India. Probably you need for a proof of FDA, you need probably randomized trials.
Okay, you see the expansion here is quite good. The most problematic part is the mid part of the stent. Yeah. That we have post-dilated a little bit with the 3.0, okay, 20 atmospheres, good expansion, and now this is
Another one.
the more tight one, I think, the most under-expanded part. But
22.
as you can see, it's not bad, okay? Okay, let's do IVUS now. At the moment, we have used 30 degrees of contrast. The last creatinine of the patient is 2.1, I think, after prehydration, and of all the work that the clinical cardiologist did. And in some papers, some colleagues call the ultra low contrast procedures those in which the ratio between the contrast use and the glomerular filtration rate does not get over 1, but probably using 40, 50
Vamos a cogerla porque es que
cc's of contrast in this kind of procedures is quite good for these patients. Okay. We're going to check again with the IVUS. Por los 2.000 más de parina. Okay. Okay, this is the distal part. Pull back. Let's check if is there any dissection or something at the distal part of the stent. There is no dissection. The expansion is good. The position is good. This was the less calcified part, I think. Any more questions, Clara? This is the MSA, I think, this part. I think it's quite good.
We don't have any more questions.
Thank you. Yes, the stent is not a circle at the more calcified plaque, but if the minimal stent area is over 5 or something like that, I think the result is quite good. The proximal part of the stent is also okay. Okay, let's retrieve the IVUS. Can we measure, please?
Laura, please. Is the
MSA.
The minimum in 6.
Right now, we have another question.
Mm-hmm.
That is, how's the follow-up for these patients with renal disease?
Well, the patient is admitted in the clinical department, cardiology department, and is going to be followed by the cardiologist the next hours, days, just to check the creatinine and the state of the patient after the procedure. So the patient is not going to be discharged today, for example, and we will check how the kidney goes.
Yeah, but we have a specialist in acute failure and advanced acute failure, and probably they follow up this patient.
We are checking the minimal stent area. I don't know if this is the worst one, Laura. Okay, click in B2 bookmark, please. B2. No, I want to see it. So 7.2 millimeters square is quite good, and more proximal, because in the longitudinal view, I don't know if it's the worst part. There, for example, a little bit more distal, There, I think is the but for sure over 5 or 5.5. I think we're done here.
Yeah.
So let's go for the circ.
Yeah.
So the result of the lady is quite good. We are not injecting any more contrast here because we have the IVUS that confirm it. So we are moving to the circ.
Mete la black sube la black un poco para que
Yo creo
no,
que está en el rango mediano.
la black súbela un poco para que esté tan abajo. Eso es la black por ahí.
Mira el rotor. Torque.
No, esa no es.
Sí, sí, esta es.
¿Esa es la black?
No,
no,
no
esa es la
esta, pero quiero esta. I'm not sure of where I am. Probably this is the intermediate branch.
Yeah.
Because the wire of the circ went back in one of the inflations. So I'm going to go back again and cross. This is the circ. I think the wire is a little bit damaged at the distal part. It goes more.
It's more right, no?
Yeah. Okay, I'm going to put the reference here if I can.
It's 23 caudal. It's 23, no.
23, okay.
Yeah.
Up. And this is, no, we have the same.
No, it's just 40 caudal, and it's just the reference projection is.
So less caudal.
Yes, less caudal.
What is the time? We have to disconnect.
Before the curve is the branch. That's okay. Is the very good.
Okay. Can I have a small test, please? Contrast. Just to check a little bit more. Un poco más. Okay, we are there. Can we have a 2-0 balloon?
Yep.
Un balón de 2, porfa.
Vale.
Sí, venga.
Vale.
We are using a 2.0 non-compliant balloon.
15, ¿no?
15.
Yeah.
Pues 12. No necesitamos.
¿Tiempo de sobra?
Yeah, we are doing only the circ branch because we are near our threshold of contrast. And I think doing this job is enough for today. We are predilating with a 2-0 balloon.
No, sorry.
And I think that our colleagues from Medstream give us some more extra time just to try to complete the left tree. Yes. Okay. For this, I think we can put the reference there. So till there, no? It's
more or less,
almost 20 something in length.
Is the black part, no? Until black part of the wire.
A little bit proximal, more proximal, I think. This is the balloon. It's struggling a little bit to cross, but I think it's crossing a little bit. I would dilate here just to reduce friction. What you're seeing is a calcified plaque.
18?
Okay, a calcified plaque with more tortuosity than the LAD. I think it has crossed a little bit more.
$18 also.
You can see the expansion quite well. And the balloon is crossing very nicely now. I will do the last one here.
Yeah, probably yes.
Redilate everything going backwards, and then IVUS here.
18.
I think there are some bubbles in the balloon,
Yes, yes.
but probably the
Okay.
expansion is nice. We will see in IVUS.
Yeah.
Inflate, please.
Habría que probarlo un poquito, ¿no?
You have seen in the hemodynamics. Okay. I think it's under expansion there. Probably.
I'm not sure.
I'm not sure about that. Let's try with an NC 2.5. ¿Me dejáis un NC 2,5, por favor?
Sí, yo creo que el balón es más grande. Sí. Y lo purgamos bien, ¿vale?
Un balón de 2,5 NC.
Yes.
So I was telling that if you see the hemodynamics, the balloon is doing, the intra-aortic balloon pump is doing its job. Or probably without it, the inflations wouldn't have been so well tolerated. Venga. No. De la última. As we are trained with the CTO procedures, we check the ACT or the anticoagulation state every 30 minutes. And now we have administered a little bit more heparin just 10 minutes ago.
Pero con la que también, que está muy avanzada.
Está así en blue, pero sí.
Es blue, pero no hay que fiarse.
No, the 2.5 balloon goes much better than before. Probably there.
12.
Okay, I think the expansion is nice. Okay, another one.
16.
Nah, this is a good expansion in my opinion.
Yes,
Okay.
yes, it's okay.
Let's go with the IVUS. I have maintained the wire in the LAD, not using it at the distal circ, because the EVU is getting inside the circ very deeply, and we don't want to reduce any dissection or anything there. So I'm using the wire in the LED just as a security tool. So let's go with the IVUS.
Can I see the IVUS?
No,
Okay.
we have the flex vision here, and we are changing this reference for the IVUS.
Yes.
Yes, Pilar is asking us if we have put only one stent in the LED, but it's at a stent of 60 millimeters. So it's like 2 or 3 stents, conventional stents. Let's see the IVUS cross because it's so tortuous. I think it's crossing, and probably I am near the distal landing zone. Probably a little bit far there. Okay. It's a small vessel here, probably 2O. Out of plaque there, some calcification, but not severe at this point. Here the vessel is bigger, some dissection after the dilatations. More calcified here. Here, but I think there are some fractures there. And this is the proximal part and the branch. Okay. This is the proximal circle. Okay, we can stop here. Let's go out. Can we check it, Laura? B1 is the distal, right? At this, okay. And the length?
Esa es la longitud de la luz, ¿eh? Es 220 es la luz. La capa media yo creo que es un poquito...
Ya, pero hay que ser...
Pues si medio igual entra, ¿eh? Lo digo porque arriba es más... Arriba ya sí que... ¿no? Arriba...
It's a very long distance. I don't know if we have to cover everything.
We have two more questions.
Okay,
The first one is, which contrast agent are you using?
Guillermo.
Isosmolar agent, the name is VCPAC. It's from General Electric. It's not low osmolar. It's iso-osmolar.
Okay, thank you. And the second one is, how much was your target of dye use?
40.
Okay,
40,
Thank you.
more or less 40. No, it's not a exact cutoff, but more or less 40 because of the filtration rate. I think that 50 was too long, Laura.
How long is Laura?
We are moving the distal and proximal landing zones.
and we have another one
Mhm.
right now. What stent did you use and what drug does it use? Is it less expensive?
Yes, it's a sirolimus eluting stent. This is the morph stent. Sorry, I'm going to check the IVUS and then answer the question.
Yes,
Okay.
it's the same price
The proximal part.
in our hospital because
Okay.
we have public prices and all stent cost the same price. In Spain, it's a public health system and it's the same price for all stents. No difference in the price.
Okay, thank you very much.
I think the proximal landing could be here, not so proximal. We have some debate here because the previous angio, the length is, in my opinion, near 30 or 30 something. Yeah, and the initial IVUS measurement said that it was nearly 50.
2,5, 38, 48, 2,5.
38 quizá, ¿no?
38 yo creo, ¿no? Yo por lo que veo aquí.
And the distal bookmark, please, just to check the 230, ¿eh? Vamos 225, y pues ya estamos.
225, bueno.
Can we have a synergy stent 2.25, 225, 38? So regarding the last question, in between we are looking for the stent, 38, no?
Vale.
The stents are similar in price, but probably if you use only one stent, a very long one, you are saving the cost of one stent.
Yeah.
So it's a debate.
But it's the same
Price.
It's the same price.
Yeah.
It's not different with the drug. No,
It's true.
it's sirolimus, verolimus. Every
Another question.
We have two more questions. The first one, which is the longest stent you have?
This one, the morph one, is 60 in length.
60.
Yes.
Okay. And the second one is
Yes,
the
Maria.
is the volume of coronary cases steady and structural going up?
Is there, I can hear you.
Yeah, that the question is that is the volume of coronary cases steady and the structural going up? What do you
Guillermo.
think?
Yes, I think so. The cheap coronary procedures going up. The complex is going up, but the number of the procedures is similar, is stabilized, and the structural procedures going up a lot.
Okay, thank you.
Contrast, please. Let it be only just to check if we are in the site.
Yes, okay, I think a little more down.
More
¿no?
que?
Down o no? Está muy arriba, ¿no?
I don't think so.
Un poquito más.
Okay. I think it's the position. Look the previous angio just to. No, this one, not this one.
The proximal circumflex, I think, is good, no? It's okay.
Yeah,
No?
just proximal to the branch, no?
Yes, but 8 millimeters, no, more or less.
Just proximal to the
8
branch.
millimeters for pot.
Probably there. Eh? Okay.
It's close.
Okay.
It's close. Okay.
Let's implant here. And we have 2.5.
This is 2.5.
No, this is 2.25, and we have a 2.5 to post
Yeah.
Even at 2.75, I think.
12.
I think the expansion is quite good.
Yes, 12 is nominal value, nominal pressure.
Laura, in the mid part is 2.75 or 2.5?
And in the proximal part?
2.5 de lumen.
Yo podría ahora con el 2,5, ¿no? Y
2,5, 2,75 es la opción.
pero como somos un 2,25 y hemos ido a... Bueno, el 2,44 hemos ido, ¿eh? Hemos subido a 2,44.
Venga, déjanos el balón de posdilatación de 2,5 que tenemos.
Sí, hay uno de ese medio ahí.
We're going to post dilate with a non-compliant balloon, the proximal part of a stent. Okay. Hemodynamics are good. SS.
Okay.
Okay.
Y la parina bien, ¿no?
We can perform an ICT, a CT. ¿Este qué? Ok, tengo. I don't know, Clara, if you have information about the time we have. This is an inflated balloon.
Yeah.
I'm there.
Use.
I'm there. Okay.
No, it depends. It depends. No. For example,
Vale. Okay.
TAVI, for example, is similar, but no, it's the same. It's similar, very similar. Only the difference can be 500 or 1,000 euros between TAVIs.
Okay.
Left appendage is similar. All devices is the same because it's a public price. In general, one procedure,
We don't know.
different devices, but one price. Me he ido. Bueno, voy a pegarle aquí 20, ¿no? Porque esto ya es la parte proximal.
Okay, I think the expansion is quite good. Let's retrieve the balloon and do IVUS to
¿Has cogido
confirm.
la parte proximal? Sí.
Sí.
Ahora sí que podemos chequear, ¿no? Con IVUS. A ver.
IVUS. We're going to check with IVUS that everything is okay. And I think if it's okay, we can finish the case now if we don't have any issue.
Are you using a maquette? The balloon pump that we are using is maquette.
As we said before, the IVUS, in these cases of low or ultra low contrast, needs to be used once and another time. We are going to do 5 or 6 pullbacks just to save contrast. ¿Qué?
No, los franceses han debido fallar, ¿no?
¿Mm?
Los franceses igual han fallado entonces,
Mm-hmm.
¿no? Si tenemos todo el tiempo.
We are advancing the IVUS. Come with me. Yeah. Okay, I think I'm there.
Okay. It's good.
The distal vessel.
We have another question from the audience.
Mm-hmm.
Are you using any ultra high pressure balloons?
And here, the OPN balloon is not at our disposal. We have the Sapphire balloon that is similar, but not achieve that high atmospheres. But on the other hand, we have all the other plaque modification techniques, lithotripsy, rota, laser, and orbital. So we manage all the cases with them.
And how high do they go? Do these pressure balloons go? How high can they go?
I think the instructions are up to 35. The stand is okay. But some colleagues are using up to 45, 50. They have a special syringe to inflate the balloon. But as I said before, we don't have experience with them here in the hospital. In the meantime, we have done the IVUS. Laura is measuring the MSA. In general, the stent is okay. The distal edge of the stent is okay. There is no dissection. This is the MSA probably near 5, but this is a smaller vessel than the LED. I think over 5 is a good result. Let's check if it's another portion worse than that. Don't think so. I think before this one is the MSA. So 5 point something. What do you think?
And the last question is, to preserve dye, OCT is automatically excluded in this case?
Yes, we have answered this before. Not automatically excluded. You can use OCT with saline or even with dextran to avoid contrast. But in my opinion, if you have IVUS, for these cases, IVUS is the preferred option.
Yes, the question is necessary to cross dilate more or with
I think that
2.75 or
this
no?
is not a cut off 5. This small vessel, you have to take into account the
I think it's good.
I think it's a good result. I think it's a good result near 5 in a vessel. The distal part is near 2.25. So I think we are done.
Podemos hacer una bien, ¿no?
This is the old school. Guillermo is asking me to do a last angio.
A good angio.
This one, let's do it.
No, pero con la de coronaria izquierda normal. ¿No?
Alejandro, that is one of the clinical cardiologists. I know if you agree with Guillermo, we are doing the last angio, but you have to hydrate the patient a little bit more.
6 is more, I think.
Rellena. Okay, let's do that. Fine.
Nice.
Very nice. No?
It's very nice, no?
Okay, let's go. So I think we are done. We are retrieving the wires and the guiding catheter, and we will manage with our colleagues here if we can retrieve the interactive balloon pump. That I think so. So that's all today here in La Paz. See you if you don't have any more comments.
No, si quiere que seguimos, bueno, tenemos tiempo aquí, ¿eh?
We're going to retrieve the balloon. I think we can disconnect and finish the case now. So thank you for the audience.